Golden notes: gastroesophageal reflux disease. It results in heartburn, affects approximately 30% of the general population. Pathophysiology: occasional episodes of gastroesophageal reflux are common in healthy individuals. Reflux is normally followed by esophageal peristaltic waves that efficiently clear the gullet. Alkaline saliva neutralizes residual acid and symptoms do not occur. Now, gastroesophageal reflux disease develops when the esophageal mucosa is exposed to gastroduodenal contents for prolonged periods of time, resulting in symptoms and, in proportion of cases, esophagitis. Several factors are known to be involved in the development of gastroesophageal reflux disease, and these are obesity, defective esophageal clearance, abnormal lower esophageal sphincter, reduced tone or inappropriate relaxation, hiatus hernia, delayed gastric emptying, and increased intra-abdominal pressure. In fact, the most important physiological mechanism that prevents reflux is parasympathetic stimulation of the lower circular smooth muscle fibers of the esophagus. In fact, scleroderma and lifestyle habits such as smoking, caffeine, and alcohol consumption, and when the angle of his enlargement is more than 60 degrees, those are all associated with gastroesophageal reflux disease. Remember that with hiatal hernia, more than 90% of patients with severe gastroesophageal reflux disease. Let's go to the clinical features. In fact, the major symptoms are heartburn and regurgitation, often provoked by bending, straining, or lying down. Water breath, which is salivation due to reflex salivary gland stimulation as acid enters the gullet, is often present. The patient is often overweight. Some patients are woken at night choking as reflux fluid irritates the larynx. Others develop odynophagia or dysphagia. A variety of other features have been described, such as atypical chest pain that may be severe and can mimic angina. It may be due to reflux-induced esophageal spasm. Others include hoarseness, acid laryngitis, recurrent chest infections, chronic cough, and asthma. The true relationship of these features to gastroesophageal reflux disease remains unclear. In fact, diarrhea may occur with the using of magnesium hydroxide, which can act as an osmotic laxative. You should note that symptoms do not correlate with mucosal status at endoscopy appearance. Investigations: endoscopy. Indications for upper gastrointestinal endoscopy. The age is more than 55 years. Symptoms more than 4 weeks or persistent symptoms despite treatment. If there is any dysphagia, relapsing symptoms, or weight loss. The most common endoscopic finding associated with esophageal mucosal injury is reflux esophagitis. If endoscopy is negative, consider 24-hour esophageal pH monitoring. It's the gold standard test for the diagnosis. And it is indicated if the diagnosis is unclear or surgical intervention is under consideration. So you should remember that young patients who present with typical symptoms of gastroesophageal reflux without worrying features such as dysphagia, weight loss, or anemia can be treated empirically without investigation. And you should also remember that a normal endoscopy in a patient with compatible symptoms should not preclude treatment for gastroesophageal reflux disease. The lifestyle advice should be given, including weight loss, avoidance of dietary items that the patient finds worsen symptoms, elevation of the bed head in those who experience nocturnal symptoms, avoidance of late meals, and cessation of smoking. Patients who fail to respond to these measures should be offered PPIs. which are usually effective in resolving symptoms and healing esophagitis. Recurrence of symptoms is common when therapy is stopped, and some patients require lifelong treatment at the lowest acceptable dose. When dysmotility features are prominent, domperidone can be helpful. There is no evidence that Helicobacter pylori eradication has any therapeutic value. Proprietary antacids and alginates can also provide symptomatic benefits. H2 receptor antagonist drugs relieve symptoms without healing esophagitis. Long-term PPI therapy is associated with reduced absorption of iron, B12, and magnesium, and a small but increased risk of osteoporosis and fractures. The drugs also predispose to enteric infections with Salmonella, Campylobacter, and possibly Clostridium difficile, and have recently been shown to have an undesirable impact on the composition of the gut microbacteria. Long-term therapy increases the risk of Helicobacter-associated progression of gastric mucosal atrophy, and Helicobacter pylori eradication is advised in patients requiring PPIs for more than 1 year. Patients who fail to respond to medical therapy, those who are unwilling to take long-term PPIs, and those whose major symptom is severe regurgitation should be considered for laparoscopy anti-reflux surgery. Although heartburn and regurgitation are alleviated in most patients, a small minority develop complications such as inability to vomit and abdominal bloating, the gas bloat syndrome. So let's focus on some points over here. Lifestyle changes. Small portions, avoid eating less than 3 hours before bedtime, avoid foods with high fat content, avoid nicotine, alcohol, coffee, and certain drugs like calcium channel blockers and diazepam. Proton pump inhibitor. If lifestyle changes are ineffective, 1 month's course of proton pump inhibitor, full dose PPI for 1 month will typically result in healing in 76%. Continuation for a further month increases this by a further 14%, which means about 90% total. And those failing to respond to 2 months of full dose therapy, doubling the dose of proton pump inhibitor for 1 month increases response rate. Can also increase the dose to twice daily therapy. Now, in those failing to respond to a double dose of proton pump inhibitor, an H2 receptor antagonist may be added or substituted in treatment, or a prokinetic agent added to treatment. In fact, a regular maintenance low dose of most PPIs will prevent recurrence of GORD in about 70 to 80% of patients, and should be used in preference to the higher healing dose. Now, the laparoscopic fundoplication, the treatment of choice for patients with GORD refractory to or intolerant of proton pump inhibitor therapy. The patient should have had an endoscopy within the 6 months prior to surgery to exclude any unsuspected pathology such as Barrett's esophagus or adenocarcinoma. The most useful in assessing the role of surgery is esophageal motility and pH study. So first line, lifestyle changes. Second line, proton pump inhibitor. Third line, H2 receptor antagonist like cimetidine, ranitidine. Fourth line, surgical Nissen fundoplication or hiatal hernia repair. Now, if we are giving a standard dose of PPI for at least 8 weeks, once daily therapy, if there is no response, then further diagnostic evaluation. If there is partial response, then increases the dose to twice daily therapy. If there is good response, then discontinue PPI after 8 weeks. So, and if symptoms recur after discontinuation of PPIs, then maintenance therapy. So after 8 weeks of initial treatment, reduce PPI to lowest effective dose. Now the complications. In fact, metaplasia of the lower esophagus which is the first stage of Barrett esophagus. Esophageal strictures occur in 10%, and adenocarcinoma of the lower esophagus. Anemia, because of iron deficiency, can occur as a consequence of occult blood loss from long-standing esophagitis. This was provided by the SSSM Study Smart Series for Mrcp, your easy way to easy pass. Remember that the references and sources for the Golden Notes are Davidson, Oxford Handbook Series, Essential Revision Notes for Mrcp, and Notes and Notes. Don't forget to follow us on Facebook, Telegram, and YouTube channel. And remember, with SSSM, you're always in a safe zone and you're always the winner.